The title Gavin gave me was The Pipeline of Novel Agents, and I've subtitled it Dealing with the Deluge. But I do have to apologise, I don't have a conflicts slide, but I have participated in advisory boards for Roche, BMS, Merck, AstraZeneca and Gritstone, which I'll be talking about relevant drugs here. So I guess it's obvious from what you've heard already and what you'll be hearing later this afternoon. We've got a large number of new agents, a lot of combinations. Mouse models don't really predict what's going to happen in people, so there are a large number of trials that are happening, and the number of trials increases each year. And across tumour types, there are actually more new trials in lung cancer than any other tumour type, including melanoma, with the large number of agents. And it's not a bubble, it's lots of bubbles in terms of the types of trials that are going on. And if you can imagine, these are different immunotherapy agents, and they're being combined with standard therapies, they're being combined with other agents. And we do have, for a lot of the trials, the backbone that they're combined with the PD-1 or PD-L1 inhibitors, and there is a bit of repetition in that each PD-1 or PD-1 agent seems to want to do similar trials with similar combinations. So how do we deal with this? So my talk's got two parts. The first, I'm going to talk about some novel trial designs for dealing with these combinations. But I'll also, you'll hear about some of the new agents later this afternoon, but I'm going to talk about some new cell therapies and tumour neoantigen vaccines, which are part of the pipeline. So starting with novel trial designs, there are a couple of different trial designs called basket trials and umbrella trials that are relevant to immuno-oncology. So basket trials are when you look at one drug or one combination across multiple diseases. And this is actually a pretty well-established pathway for doing trials. Now, this is a flow diagram for the phase 1 clinical trial with pembrolizumab. So one drug, and this is actually just two diseases with multiple different doses and settings, but now we're seeing with a combination, even from the start of the phase 1 study, multiple different expansion arms will be identified in the study, and that's really become pretty standard now for a phase 1 clinical trial. What's less common, and which we're starting to see more of, is this umbrella trial, where you look at one different disease, for example, lung cancer, and then in one trial evaluate multiple different arms within the trial. There are advantages to this design because it's flexible. You can add new arms as new combinations arise. You can close arms if they don't seem to work or if they have unacceptable toxicity, so that the trial can change in its lifetime. This is an example of one such trial we have open. It's a pretty complicated trial. It's got two different cohorts. It's got a cohort in the first-line setting, but also a cohort in patients with lung cancer that have progressed through immunotherapy. The protocol's got 490 pages. There are 12 treatment arms, and actually there are 13 different consent forms for the study. So it's quite, we've got some of our clinical trials team in the audience, it's quite a challenge to wrap your head around. But this is an example of why this type of study is a good study. So this is cohort 2, which is in patients who've progressed on prior immunotherapy, so they might have had nivolumab in the second-line setting and progressed. In the first part of the study, they can get allocated to one of 6 different treatment arms, including a control arm, which is docetaxel. So there's multiple exploration of different arms, comparison with the standard arm. But if that patient enrolls on study and their cancer progresses on treatment, they don't have to come off study. They can swap over to 2 of the other arms that are on the study. So this is a very efficient trial design in looking at multiple different combinations in the one trial protocol. Another new way of doing trials, I think Ken described a very similar trial, is looking at immunotherapy agents in the neoadjuvant setting. This was a trial with nivolumab prior to surgery in patients with early stage lung cancer. So this is a trial with just 2 doses of nivolumab over 4 weeks. The pathological response is shown here. We're actually now doing a phase 3 study of neoadjuvant chemotherapy plus immunotherapy. But I think this setting provides a great opportunity to look at novel combinations and learn a lot at the same time about the biology of these combinations and get an early readout on how effective they are in as little as 4 or 8 weeks. I'll move on to the next part of my talk, which is cell therapies and vaccines. So with a lot of the treatments we use, the ultimate effector arm of the immune system is the T cell. And shown in this cartoon are the good guys in blue targeting a cancer cell in yellow. And the T cells uniquely identify neoantigens on the surface of cells that then become identified as foreign and target them for destruction. And a lot of our efforts go around ways to enhance this. So one way is to actually take T cells out of a patient and put them back in a way that they work better. And this is called adoptive cell transfer with tumor-infiltrating lymphocytes. This is a not straightforward thing to do. What you need to do is you need to excise part of the tumor, separate the lymphocytes from the tumor, select the ones that have specificity for the tumor, and then before returning them to the patient, usually give them additional treatment with lymphodepleting chemotherapy and interleukin-2. In metastatic melanoma, this has been done for some time with a reasonable response rate. There's an example of a patient with a subcutaneous nodule that's had a good response shown. But there are a reasonable number of patients treated with these approaches, and about 10 to 15% of these patients get durable responses, maybe even cures. But it's not, as I mentioned, a straightforward approach. It can be difficult to get enough lymphocytes, and there are various other conditions that need to be met in culture to select the lymphocytes you want, their toxicities associated with the interleukin you need to give. But I think it's an approach that has shown some promise in melanoma. Recently, this has been explored in the setting of lung cancer, and I think a really very interesting trial design. So this was a trial from the Moffitt that was reported at Toronto at the recent World Lung Cancer Conference. So what they did is they took a group of patients with advanced lung cancer, they resected a metastatic deposit, took out tumor-infiltrating lymphocytes. Then they treated everyone with nivolumab, a PD-1 inhibitor. And if the patients had a response, they continued on with the nivolumab. But if they had progressing disease, then they went on to the next part of the study where they received the TILs. They needed to have chemotherapy with cyclophosphamide and fludarabine before they got the TILs. They got the TIL infusion, they got some interleukin-2 as well. And what the results of the study were, I think, promising, certainly not a home run, but suggests that there is some benefit in this approach. So shown on the left are what happened with the size of the tumours in the patients that received nivolumab. A couple of the patients had reductions in their tumour size and continued on with the nivolumab. But most patients had pretty early progression and went on to the next part of the study. And in the next part of the study shown on the right, you can see that many patients had reductions in the size of their tumours, suggesting that the TILs did modify what went on in the tumour. Again, as I said, I don't think this is a home run, but I think it suggests that there is some potential benefit in this strategy. Another strategy is, instead of relying on T cells that you extract from a tumour, to take lymphocytes from a patient's peripheral blood and modify them in the lab to specifically target antigens on a tumour. So one way of doing this, there are different ways you can do the modification. One way, which I'll talk about in a bit more detail, are these CARTs, or chimeric antigen receptor T cells. These are T cells that you can engineer to put a receptor on the outside linked to the T cell receptor that can identify a particular antigen that you choose, engineer that into the cell, and then when the cell sees the antigen, that sends a signal to the cell to divide and be activated and target the cell on which it recognizes the antigen. So you take the cells from the patient, you modify it in the lab, usually with a viral vector, and then that results in expression on the surface of the lymphocyte of a receptor that targets the antigen. Hopefully it sees the antigen on the tumor cell. Now, this is probably the coolest bit of the talk, which is a video that shows what happens when a cell, the long cell is a cancer cell, when it sees a lymphocyte, a CAR-modified T cell. So I'll just play the slide again. So the CAR T cells are in green, and when they recognize receptor on the surface of the cancer cell, they attack the cancer cell, and the red you see is the dying cancer cell. When the cancer cell dies, a red signal from the medium goes into the cell, and this is the cell undergoing apoptosis. And what you see in that video is what the aim of adoptive cell transfer using these different approaches is. It's a pretty complicated process. It involves collecting the lymphocytes, modifying them in the lab, and then returning them to the patient after chemotherapy. And it's you need to identify, and in terms of what makes an ideal target for a CAR T cell, it should be a molecule that's on the surface of the cancer cell. You really want it to be only on the tumor cell, not on normal tissue, otherwise you're going to get normal tissue toxicity. And the one that's turned out to be the best so far is CD19 in hematological malignancies. It's found in B-cell malignancies, and its expression is really just confined to B cells. And trials have been done in CAR T cells, which have shown really good efficacy and in many cases cures of advanced lymphomas and leukemias. There are significant toxicities that are associated with this, including something called cytokine release syndrome, neurological toxicities, and these trials are expensive, and they can only be done in centres with expertise, not only necessarily in the sort of cell manufacture, but also looking after toxicities. And I think this is an important slide as well. The costs of one treatment with this, with the CD19 CARTs, is $475,000. Melissa talked about the $60,000 for 1 year of pembrolizumab. This is the cost associated with CAR T cell therapy. Interestingly, on the radio, I heard an interview with the health minister in the context of CD19 CAR T cells. And I know we've got some TGA people in the audience, but he was saying as soon as the TGA approve and MSAC approve, it's the government are looking at it seriously, which is good. The point to say is, despite the cost this is coming, China has taken over from the US as the centre with a leading number of CAR-T studies. Now, it's been much more challenging in solid tumours than in hematological tumours to look at CAR-T therapy. There's difficulty in identifying a target that's sufficiently specific for tumours. It's very the microenvironment of the tumour makes it difficult to get the cells into tumours, and there are lots of immunosuppressive factors in the microenvironment of tumours. Something called on-target off-tissue toxicity is relevant. There were CARTs, and actually T-cell receptors, which is a similar technology directed at CEA for patients with colorectal cancer. But it turns out that CEA is also expressed on the mucosal surface of the rectum. So in this trial, there was very significant toxicity with colitis, which may have been predicted. We're doing a study targeting an antigen called Lewis-Y, which is expressed on a range of solid tumours, including lung cancer. The trial involves collecting cells, modifying the cells in the lab, and then reinfusing them after fludarabine and cyclophosphamide. The trial is ongoing. It's a phase 1 study. This is an example of a patient with bowel cancer that has high expression of Lewis-Y on their tumour, and the eligibility for the trial is not the type of tumour you have, but whether it expresses Lewis-Y or not. And there are various different strategies that are being looked at to enhance the efficacy of adoptive T-cell therapy, including combinations with PD-1 or PD-L1 inhibitors. And I'll just finish on tumour neoantigens, and we heard a little bit about this from Shanine earlier. This is an approach where you take a biopsy from a patient, you get their blood as well, you identify the unique neoantigens on that tumour that are expressed just in that tumour and not in any other cells in the body, and design a vaccine based on that, and then you give that to the patient. And this, to me, truly is personalised medicine. It's more personalised than targeted therapy, where you have one drug and you see whether a patient matches that drug. This is starting with the patient and identifying an approach that will work just for that patient. There are a bunch of companies that are doing this. We've got a trial with a company called Gritstone that we hope will be starting at the beginning of next year. Yeah, I'll end on that note. Thanks.